I see a COVID-19 question.
Yep. Mm-hmm.
So very, very important.
Mm-hmm.
So I gave a webinar on COVID-19 World Sickle Cell Awareness Day in 2020, and then I gave a Facebook Live in February of 2021 on the COVID vaccines. Originally in 2020, we were anticipating this is a deep-seated lung infection. It causes what looks like acute chest syndrome. The surprise is in sickle cell, people have these infiltrates and they don't get acute chest syndrome or really bad pneumonia. We were anticipating that. Big surprise. This is always a surprise with trials. Having said that, everyone, and I've had about 50% of patients get the COVID vaccines. I recommend the 2-dose vaccines, the mRNA vaccines, better protection, because sickle cell patients are a higher risk patient population. Of those who have had COVID, many get what we call long disease. We have not studied this carefully yet, but it seems to me that more of them get long disease. It's shortness of breath, inability to sleep, chronic fatigue, headaches, all sorts of bad stuff for months and months after the COVID infection. I don't know why it affects people with sickle cell more. That's my impression. We need to study this. I recommend COVID vaccines. And I'll give you my little anecdote. 3 weeks ago, I went to my first COVID-19 sickle cell funeral. It was a complete surprise to me. It was the patient who kept on telling me in clinic, oh, I'll get it next time. I'll get it next time. I don't really want it, but I'll get it next time. Never in the hospital, takes meds, takes care of themselves. They got it. They got hospitalized in another hospital. They got discharged from the hospital. They got re-hospitalized at Howard and died very quickly. It was a complete surprise to me in the patient that I wouldn't have expected it in. And this is the dilemma with COVID-19. We cannot predict whether I'm going to get sick, whether Barbara's going to get sick, even though we think we're in low risk groups. Get the vaccine. The protection against death and hospitalization for everyone across the country is dramatic. I just looked at this. As of September 20th, less than 5,000 people who were vaccinated died from COVID-19. So the majority of deaths are coming from people who are not getting vaccinated. And you just can't predict who's going to get really sick.
Thanks. How far apart should you take the flu or COVID third vaccine?
So right now, there's been a discussion around the country of sickle cell providers, and we are not recommending booster shots right now unless you're over 65. That is the group. Most of those deaths, those less than 5,000 deaths that I mentioned, most of those people are over 65. The majority are. That is a high risk group. Bonus on booster vaccines. If you're in a really high risk group, HIV, dialysis, diabetes, get a booster. I would not worry about, I would get the flu shot when you can. And the thing that the pandemic has messed up is the transmission of flu. We saw fewer cases last year than ever before, probably because we're in mass. Then there's another virus called RSV. It's usually in the winter. It usually affects little kids. We've seen it all summer. It's messed up the transmission of all viruses. Get your flu shot as soon as you can. I would not worry about it being too spaced out around your 2 COVID vaccines, and I would encourage the 2 COVID vaccines. We have not seen very many problems at all, and most importantly, no pain crises. And I just mentioned the first person at Howard to get vaccinated against COVID-19 was President Frederick, who has sickle cell anemia, and he's very public about it. He was the first person to roll up his arm. He had no problems. I think the dean passed out or got got a little faint when he saw the needle. President Frederick had no problem. So that to me made me sigh a breath of relief that sickle cell patients were probably going to be okay with the vaccine.
All right, we have another question. Please pardon me if I mispronounce it. How is Crinzelizumab different from Violexotor?
So Crinzelizumab, remember I said the inflammation, the pain in your arm after the fact. That's your white cells going there. Crinzelizumab blocks that part of pain crises. Voxelotor makes the red cells survive longer. And it really doesn't affect pain that we can see right now from the clinical trials. Crinzelizumab reduces pain by 40 to 60%, depending on who you are. I like crinzelizumab because I don't want people in the ER in the hospital. I like voxelotor for patients who are more anemic. If you're having a lot of pain, that may not be the best drug for you. And that's where you really have to go and see a hematologist who can individualize your therapy. Very good question.
Let's
I think
see.
there's another one. You
Yes.
see there's another. Go ahead.
Yes, thanks. My chat box shifted. I'm also
Sorry.
on oxygen. No problem. I'm also on oxygen. Should I still get the vaccine? I have not had COVID-19.
If you're on oxygen, you're at much higher risk. You have lung disease or something going on, get the vaccine. You're a much higher risk group. And that's where, you know, I can't even say for sickle cell disease, we have so many subgroups of patients. I see a lot of patients, so I can subgroup them into low hemoglobin, high hemoglobin, more pain, less pain, pulmonary disease, heart disease, all sorts of things. If you're on oxygen, get the vaccine. You're very high risk.
Thank you. We have another question. Is it true that COVID-19 vaccine clots the blood? I'm concerned that I will have a severe crisis.
So COVID-19 in general clots the blood. Okay, there's a blood test that we do, and it's a great marker for who has COVID-19. It's the same marker that we use for clots in the lungs. Okay, there is a small, very, very small group of patients who get low platelets and sometimes clots. Is mostly with one of the British vaccines, but the Janssen or Johnson & Johnson one-shot deal, I don't like that one because it's about 72% effective. I like 90% for sickle cell patients because it's a higher risk group. So if you're getting those mRNA vaccines, we have not seen problems with clots.
Thank you. We have another question. What is the best drug for kids under 2 years old?
So again, as I mentioned, if they have SS, hydroxyurea is very, very appropriate. We've made it easy for patients to take. And my prediction is that those kids that are starting it at under 2 years of age are going to be healthier and live much, much longer than our adults who started it in their 20s. I guess the only other treatment would be transfusion therapy, and that you'd have to talk to your hematologist about whether that's appropriate. There are complications and side effects of transfusion therapy that have to be considered too.
Thank you. Oh, thanks. We're getting a lot of questions rolling in.
Yeah, a lot of questions.
Awesome. Great questions. Are you using a DocVio for patients who do not have a history of frequent crises? In other words, are they prophylactically? Sure.
Is it being used as prophylaxis?
Yeah.
Well,
Yes.
so this is an interesting question. It costs about $100,000 a year. So very expensive. Patients don't pay that, but that's the cost. So I've been a little bit careful about making sure that we can justify it to insurance companies. But I do have some high functioning patients who have jobs and other things where I am using it and they're not in the hospital very much. Why? Because if you start talking to them, they tell you about more pain at home that they just don't like to go to the hospital. They don't want to be in the emergency room any more than I want to be in the emergency room. And they have crises at home and they can define them. And if I get a sense that that's affecting your quality of life, or we have you on high dose opioids and I want you on less pain medicine, we're using crinzelizumab prophylactically in some of those patients. Still too early to know. I've got, I think, the most patients in Washington, D.C. Again, I see a lot of patients. So we have 11 people who have been on it for a little while. We're going to know more as time goes on and we gain more what we call post-study experience. We did the trial here at Howard. That's a very different thing than actually treating patients.
Understood. We have another question. I have had a total knee replacement and it got infected and the infection was washed out. The knee implant was taken out and I'm currently on antibiotics. I have to go back for another knee replacement next month. I have not had the vaccine yet. Should I get it now or wait until all the surgeries are done?
So I would go and talk to your hematologist. You know, this Delta variant, it's spreading like wildfire. It's much more infectious, and that's the concern. COVID is, you know, I've traveled to Ebola endemic areas. Ebola is a very different disease than COVID. That's really scary, okay? Coronavirus, COVID-19, it is a big deal, but it's not Ebola virus with 50% of patients dying. I would talk to your doctor. I would probably recommend it, but I'd ask you to talk to your doctor about your specific case and reasons for doing that.
Thank you.
Infectious disease here. Infectious disease here. The COVID vaccine will not interfere with the infection from the joint replacement at all. So I would recommend, again, speak to your doctor.
If you're getting surgery and you're in the hospital and you get COVID, it could be a very bad thing.
Right. So this would be a perfect time to get that vaccination.
Thanks, Dawn.
You will.